We want to thank Acevedo Consulting and their CEO for making this presentation possible and for bringing Dr. Paul Schwartz in too.
Thank you.
And I hope to learn a lot. All you hear anymore is RPM, RPM.
Yeah,
So,
yeah, I agree, Cynthia.
Right.
Every time I turn around as well. So thank you.
thank you. So
Yeah.
go for it.
All right, we're going to go for it. Okay, so good afternoon, everybody. Jean Acevedo here. And I have the pleasure of making this remote physiological monitoring presentation together with Dr. Paul Schwartz, who is a local practicing physician. And I think he and I have divvied this up in what I would consider a logical fashion. I'll start off with, okay, what the heck is this stuff? What are the codes? What are the Medicare allowables? What do you need to document to be able to bill, at least now? And okay, so fine, well, I'm thinking about it. Immediate disclaimer, we are in, no, it's actually September 1st, 2021. We're in the middle of the time period where the 2022 Medicare Physician Fee Schedule rule has come out in its proposed format. And so if there are changes, we'll know in November, right? So don't shoot Dr. Schwartz or myself if there's something that we say now that come January isn't quite on target, right? But the Medicare program is indeed all for these type of services. So if there are changes, I can't imagine them being anything that would be draconian or something that would negate everything. So that's pretty much the disclaimer for the doctor and myself. So I know that this is an unusual time. Many of you know me and know that I've been around for a year or two. I like to say it's not that I look bad for 29, haven't been 29 in at least a year or two. And the thought that the Medicare program would be paying for non-face-to-face in-person services was something that a decade ago, I would have told somebody you've lost your mind if you told me that was going to happen. But back in 2015, everything started to change. First, transitional care management. Then the following year, chronic care management. Then a couple of years later, principal care management. And last year, the codes started coming out really for remote physiologic monitoring. There were some codes that were kind of like RPM, but and the reason I personally believe that we keep seeing this growing menu of non-face-to-face services is the Medicare program, as I'm sure you all are aware, has one major goal, which makes sense. How can we enhance the quality of patient care and beneficiary satisfaction and control or lower overall costs? And I don't know how many of you saw in the newspaper this morning the fact that whoever it is, the Treasury or whatever division of the federal government stated that the Medicare program is set to lose not to be financially viable in another 10, 15 years, right? So shoring the system up makes sense. And all of these services serve that purpose, remote physiologic monitoring being the last one to come out. And every year Medicare seems to add services, tweak prior ones that were payable, like chronic care management has gone through 2 or 3 tweaks, all of them beneficial and making it easier for physicians to provide the service. So that's my perspective on where we are and kind of how we got here. And I think this will continue to evolve. So there are half a dozen codes for remote physiologic monitoring. Now, you sometimes will see RPM stated as remote patient monitoring. In the CPT code book, it's officially physiologic monitoring. And I think that verbiage is important because it has to be physiologic data, right? So it's not a patient reporting on what their pain scale is, right? So remote patient monitoring, I think where I see it, I'm always like, I wish they would use the actual term. So there are half a dozen codes. And as you can see, the reimbursement goes from approximately $19 to about 60 some odd dollars. And how you utilize those codes obviously not obviously, but you'll learn depends on how you have implemented the services. We'll go into that a little more. So what are the codes and their documentation requirements? So here are the actual definitions. 99453, remote monitoring of physiologic parameters such as weight, blood pressure, pulse ox, respiratory flow rate. Initial setup and patient education on use of equipment. So, okay, you're going to start remote physiologic monitoring, RPM, and either you, the physician, non-physician practitioner, or your office nurse is going to help the patient get started. Show the patient how to use the equipment, educate them on how to use it, the transmissions, etc. That's what 99453 is. 99454, remote monitoring of physiologic parameters, again, weight, blood pressure, etc. Initial device supply with daily recordings or programmed alerts transmission each 30 days. So here you're actually providing the device, and this is covering the first, not the first, but each 30-day period, right, that you would be getting the information. 99457, remote physiologic monitoring, treatment management services, clinical staff / physician / other qualified healthcare professional. And I've always got to stop every time I see this other qualified healthcare professional, because I know a lot of folks aren't quite sure, who is that? And I remember the first time I saw QHP in the CPT code book about 4 or 5 years ago, I also had that question, who are these people? The AMA added this term of art to the CPT code book just a few years ago. And the easiest way to figure out, okay, who are these folks? These are your nurse practitioners, physician assistants, someone in your office other than a physician who can indeed bill an evaluation and management service, so an office visit on their own, right? So it's not your RN, it's not your dietitian, et cetera. It is indeed a nurse practitioner, physician assistant. So any of these folks, time in a calendar month requiring interactive communication with the patient or their caregiver during the month, the first 20 minutes. So during the course of the month, if you've got this equipment that is automatically transmitting results, information, data to you, right? It's a time-based code, or I should say they are time-based codes that one would use for actually managing the patient's treatment as this information is flowing to you. So 99457 is the first 20 minutes. 99458, same definition until you get to the very end, which is then each additional 20 minutes. So as any of the billing and coding staff who might be attending know, that's an add-on code. You would never bill 99458 without 99457. You have to have the initial, the first 20 minutes before you can bill additional 20 minutes. And if I'm not mistaken, this is one of those areas, just as in chronic care management, that the Medicare program requires that the full 20 minutes be met. So you would bill 99457 and 99458 once there has been 40 minutes of RPM that month. And then the 99091 code, CMS considers RPM as well. This is much more generic, and it's been around, this code has been around for a while. Collection and interpretation of physiological data, so now EKG, blood pressure, glucose monitoring, digitally stored and or transmitted by the patient or their caregiver to the physician or other qualified healthcare professional, qualified by education, training, licensure, regulation, when applicable, requiring a minimum of 30 minutes of time each 30 days. So this isn't remote physiologic monitoring in the same sense as the other RPM codes are talking about. And Dr. Schwartz will give you some really good examples after I've gone over the coding and the documentation as to, okay, how do you identify patients? What actually happens on a day-to-day basis, et cetera. And then there are some clarifications. If you were to go to the CPT code book or read Medicare articles and policies on this, you'd see that it says that you can do RPM on established patients. There must be at least 16 transmissions from the device or devices within a calendar month to be able to bill. But we are still in a public health emergency. And as I'm sure you all are aware, there are an awful lot of Medicare criteria that have been suspended, waived, relaxed during this period of time. Update on where we are in the public health emergency. Near the middle end of July, HHS Secretary Becerris extended the public health emergency for another 90 days. He has the authority to extend it for 90-day periods. So that brings us to third week, probably second to third week of October. That Medicare proposed physician fee schedule that I mentioned came out for 2022, has already some significant comments from the American Medical Association, for one, urging CMS to keep all of these public health emergency waiver billing opportunities, my words, billing opportunities, not the AMAs, in place through the end of 2023, so that CMS has time to gather data and really figure out what's beneficial from a cost and quality perspective and what isn't. So how long this will be after this calendar year, we shall see. As far as the relaxation of some of the rules, because right now, during the public health emergency, you could indeed institute RPM for a new patient. CMS came out with that for a lot of your even telehealth services, right? Because they realized that if they only allowed established patients to be able to access any type of remote, non-face-to-face service, a lot of patients would be being potentially exposed to COVID just because they didn't already have an established relationship with that physician or other provider, right? So right now, new patients as well as established patients can receive RPM from your practice. Auxiliary personnel may provide services described by 99453 and 54, the incident to the billing practitioner, and under supervision. And the supervision, some of you may realize and have had the benefit of practicing during the public health emergency, for incident to services has been relaxed to general supervision, right? So again, to try to avoid patients traveling, being exposed unnecessarily, and you being exposed unnecessarily if your patient hasn't been very good about taking care of themselves and taking proactive measures during while we have COVID. But importantly, this next sentence is something that makes it a lot easier for folks to be able to implement RPM. Auxiliary personnel may include contracted employees. So if you think about it, one of the things, and I know I've seen this with all of these non-face-to-face services, is what's your stumbling block? How the heck do I get started? Where would I begin? And that's why there are indeed companies out there that can help you with chronic care management, principal care management, and RPM as well. So that at least you have an avenue and someone hopefully with good experience to be able to get that started for you. The medical device supplied to the patient as part of RPM must be a medical device as described by Section 201H of the Food, Drug, and Cosmetic Act. That's going to remain even after the public health emergency. It must be a medical device, and that the data must be electronically, i.e. automatically collected and transmitted. So, and again, rather than self-reported. So I had a physician recently ask me about, the patient sharing their different fingerstick glucose results, right? And nope, that's the patient. It's not the technology automatically transmitting the information to you. after the COVID public health emergency ends, so let me back up. So you would see in all of the guidelines that, okay, so I've got my month. How many interactions do I have to have between my equipment, the patient and their equipment, and my practice to be able to bill? I mean, if the patient just transmits once, am I good? No. So the requirement is 16 days of data in every 30-day period. But again, during the public health emergency, that was relaxed. So a minimum of 2 days of data is allowed. I know if I was starting this, I would actually be starting this probably with, and Dr. Schwartz may, when he's talking, may tell me that I'm silly to do this, but I would want to start with, okay, what's the best practice, which would be 16 days. Were you going to say something, Doc?
I was going to say never. Would I say that?
Oh. And then who can bill? So physicians, non-physician practitioners, those other qualified healthcare professionals, nurse practitioners, physician assistants. So anybody who can bill for an office visit. So no, a physical therapist cannot provide RPM and actually bill for it, right? A licensed clinical social worker, no, cannot provide RPM and bill for it. A company on their own that has the equipment, knows how to set everything up, has a program, cannot get a Medicare provider number as a supplier and bill for it. And then very important last bullet on this slide, that the remote physiologic monitoring service must be medically necessary. So it needs to be that there's a real need for the patient to have this. I'm going to give you a silly example. So if there is some type of remote monitoring for my blood pressure, and I don't have hypertension, I've never had any orthostatic hypotension, right? It's just that sounds like a good idea. It's not a billable service because there's no apparent medical necessity for it, right? So that type of underlying criteria for whether or not you should be billing and can get paid, and if you do get paid, you get to keep the money. The medical necessity criteria is the same as with anything else. And feel silly even telling you guys that, because other than like annual wellness visits, screening mammograms, screening PSAs, other preventive services, everything has to be medically necessary, right? And the area, though, that is new during the public health emergency is that the patients can have an acute condition. So it doesn't have to be that there is an ongoing chronic condition. You could actually implement RPM while the patient is maybe first initially diagnosed with something where you'd really like to have some data to help get them under control or to confirm your diagnosis, right? When a patient first presents with symptoms or some abnormal testing, that you're allowed to do that as well. You know, there's no requirement that this happen every single month for the rest of the patient's life, so to speak, right? So I'm going to stop for a second. I see there's a couple of chats, so let me ask them before I forget. Are medical assistants able to provide 9945354 under the supervision of a physician or non-physician practitioner? Yes. Oh, never mind. I answered the question. Okay, sorry. All right. Whoops. Where was I? All right. So the some clarifications and revised policies continued. So for 99457 and 58, understand that an interactive communication is a conversation that occurs in real time and includes synchronous two-way interaction that can be enhanced with video or other kinds of data as described by CPT code G 2012. The 20 minutes of time required to bill for the monthly RPM, 99457 and 58, can include time for furnishing care management services, as well as for the required interactive communication. So the interactive communication with the patient, right? So that's another thing that CMS has done, knowing that more and more physicians are implementing chronic care management, transition care management, some of the virtual services, virtual check-ins, and maybe RPM, right? It starts to be very confusing. Wait, if I'm doing one of these, do I have to not bill for something else in the course of a month? Since many of those are, within a 30-day period or a calendar month. So they've also lessened some of the requirements for that. The fact sheet for remote physiologic monitoring for this year clarified that after the COVID public health emergency ends, there must be established patient-physician relationship. Just want to make sure that that's clear, that again, right now, you could implement this for a new patient. In fact, depending on your specialty, this might be a way to determine whether or not the patient actually needs to be seen by someone in your specialty. Consent needs to be there. For all these non-face-to-face services, CMS has been pretty upfront about the fact that you need to make sure your patient you have documented that your patient actually consents to these services. And I really think that's because the Medicare program, CMS, that patient's not seeing you in the course of a month. And CMS itself has had their senior fraud task forces, right? So anybody who has Medicare gets a little notice on their explanation of benefits saying, if you don't recognize this, call the hotline. So they want to make sure, I personally believe, that the patients have been advised that, hey, if you agree to this service, it's covered by Medicare. Don't be surprised if you see on your explanation of benefits that there's been a payment for this, right? So finalize the consent to receive RPM services may be obtained at the time the services are furnished. So it doesn't have to be in advance, very much as they did for the telehealth services. Finalize that auxiliary personnel may provide services described by 99453 and 54 incident to the billing physicians and under their supervision. And that again, that it can be contracted employees, right? Doesn't have to be one of your full-time staff. Clarify that the medical device supplied to the patient needs to be considered a device by the FDA, and it must be reliable and valid, and that the data must be electronically, automatically collected and transmitted and not self-reported. Clarified that after the public health emergency ends, again, you have to go to that 16 days, not just the 2 days that you're allowed now of collecting it, the information and having it transmitted to you and analyzing it. And of course, what I had said a moment ago, the fact that only physicians and non-physician practitioners, your nurse practitioners, PAs, are eligible to bill the service. That doesn't negate the incident to component for your auxiliary clinical staff. Can be medically necessary with patients with acute conditions as well as chronic. And that an interactive communication is a conversation that occurs in real time. Synchronous two-way interactions, so it wouldn't be a message through the portal on your EMR and that you respond to tomorrow. That would not be considered an interactive communication. And that the 20 minutes of time required to bill for the monthly services, the 99457 and 58, can include time for other care management services, right? So you don't have to worry about double dipping. Okay, so I am going to turn this over to Dr. Schwartz. I've filled your head with technical coding and documentation and requirements. And I'm going to stop sharing so that Dr. Schwartz can bring up his, unless, Paul, if you have issues, I'll bring mine up and you could always do the next slide, please. But nope, you have no issues, young man. There you go.
Okay, I just have to get to the right slide on the slideshow. There you go. Okay, so good afternoon, everybody, and thank you, Jean, for including me. I appreciate that. So how do you identify patients who qualify? How did I start out doing this? And so I really started with the patient who is labile hypertension. That was the patient I was having difficulty controlling, or who came to the office always saying that their blood pressure was high every time I took it because they had white coat hypertension. And sometimes when we did the remote patient monitoring, we found that they were right. They had normal blood pressure at home, and then that was usually a quick RPM service, 1 to 2 months of service. Then we determined that they had stable blood pressures, and then we could discontinue that. Other times, we found that the patients had very labile blood pressures and they required medical management and sometimes referral to a nephrologist or cardiologist for further management. And then we wound up getting control of their blood pressure. And sometimes, even in one case, we found one woman was really having what the nephrologist called a pseudopheochromocytoma, and she actually wound up being treated by a psychiatrist for for severe generalized anxiety disorder, which drove up her blood pressure. And so the RPM actually served a very good purpose there to identify patients who weren't responding to antihypertensives appropriately, and gave us insight into how to manage them. Poorly controlled heart failure patients or COPD patients, the RPM kits, depending on which peripheral device you choose to use, and you can use more than one. You can use blood pressure cuffs or scales. You can use spirometry, pulse oximetry. And so it gives you some insight and control over what's happening with your patients. Normally, as Jean had mentioned, chronic disease management for conditions such as diabetes and patients transmitting their blood sugar data, but now even in acute management during the public health emergency, newly diagnosed patients are appropriate for RPM. We found that recently discharged patients from the hospital in transitional care services are prime candidates for remote patient monitoring, in that it gives the provider great insight into what the patients are doing, specifically for heart failure patients. Those that would have gained maybe a pound or two in a day, you can then interact with them and discuss what they're eating. Perhaps they had some canned soup or some other thing, and sort of educate them about those social determinants of health, and gives you more insight. And then if you do a direct telemedicine visit with them, as you would have to have direct interaction, you can actually get some insight by really seeing inside their home. Postoperative care for patients with poor insight into their conditions and those that are non-compliant with medication. The remote patient monitoring does help you to say, hey, are you really taking this medicine? And one of the caveats, of course, is that you have to pick patients who will be willing participants and actually collect their data, because if they don't collect the data, then you can't really get the benefit of having the data to talk to them about. And of course, as Jean said, if you don't have those 16 data points, then you're not really you're not able to bill after the public health emergency. If they do 2 now during the public health emergency, you will be able to bill. But while it is an opportunity to create revenue for your office, if we all approach it by looking just at improving patient care that we get paid for, that I think is a better way to look at this. So just as a little bit of data here, during Becker's Hospital Review recently published that in the Centera healthcare systems, they used RPM more robustly, and that they reduced their hospital readmissions to 2% compared to 15% for the hospital at large, for those patients that didn't get RPM. So practical implementation tips. Well, who's going to be the vendor for the RPM services? How are you going to choose your vendor? And there are numerous vendors out there. Just as we also provide vendor services as just as a matter of self-reporting there. But who are you going to choose? There's many vendors out there. Is the vendor just going to deliver a piece of equipment to you that you give to the patient and then bill you monthly for having that piece of equipment? Or are they going to be more supportive? Are they going to go through training with you? Do they provide a platform that you can use that gives you a dashboard where your data can be easily reported and incorporated into your electronic health record? Or are you responsible for now somehow acquiring that data in terms of it being reported to you? How is it being reported? What training and support does the vendor give? If your patient has a problem with their device, who do they call? Do they call your office or do they call the vendor? How much technical support will that vendor give you? Do they call you if your patient's not collecting their data? Is there some way for them to inform you if are they watching? Are they your backstop, so to speak, in regard to your RPM, or are they just generically giving you a piece of equipment and telling you to have a good day and have at it? And they told you can bill all these codes that Gene had told you, and you can make X amount of dollars a month, and if you just have at it. And or is the data EMR agnostic? Sometimes you have to look at these things and do you need an API interface to get the data into your EHR? And is it even worth doing that, or can you just print the data like a PDF and incorporate that into your EHR like you would any fax that you get? And that's what I do in my own office. I collect the data, and we actually just download it and then upload it into the EHR like an attachment. And when I do my visit with the patient, I do a telemedicine visit with them. Is the kit that is included for your remote patient monitoring, does that give the patient the capacity for actually doing a telemedicine visit on that device, or is it a completely separate device? Does the vendor offer more service lines, or are they just solely doing RPM? So there's so many things to consider when you're choosing the vendor, but the right vendor will certainly be to your advantage. And then what RPM kits are you going to get? You have to have an FDA approved peripheral device, and there are roughly 17 or 18 approved FDA devices: spirometry, blood pressure cuffs, scales, pulse oximetry, glucose meters, et cetera, et cetera. And then is that all self-contained in one kit that transmits the data, or is there some other intermediary device like a tablet that's necessary? And is that tablet then able to do 3G, 4G, 5G, or Wi-Fi? How do we approach that, the connectivity of the patient? And then is the vendor going to help your patient get connected? And then size and weight. We've heard of a variety of different types of devices, but is the patient really going to use that at home? Are they going to take that with them? Is it cumbersome or difficult to use? So those are some considerations for the equipment that you might want to consider. And then, of course, how do you get started doing this? Are you going to use a third-party vendor, or do you want to keep more control of that in your office? So what we did is we chose a champion in our office. One of my medical assistant, Linda, would work with me to actually work on initiation of the program. And then how's the data going to be managed? Does the RPM company offer you an app on your phone? Do they offer you alerts? Are you going to be able to set parameters so that you get pinged on your phone if a patient exceeds a blood pressure that you don't like, or if a patient has a blood pressure of 200 over 100 and it's sitting there on the data, but you didn't get pinged or aware of that, So some of these programs allow for the provider to be pinged if the data is out of a certain range that they themselves set. And how adjustable are those parameters? So how do you want to manage your data? And then how do you want to incorporate that data into the medical record? Those are key issues, because really when I met Gene and we started talking about RPM, I said, okay, let's start from this perspective. When I get audited from doing this, what do you want to see in my chart? And that's how we went about it. We sort of worked from that point. We're going to get looked at. So how are we going to try to make this as solid as we can by having our medical record look polished and professional, and also meet and check all the boxes of all the requirements? And so incorporating the data into the medical record is important. And then how are you going to integrate this into your office workflow? All the doctors here are going to say, oh, anything that disrupts my workflow is terrible. I hate it. How am I going to incorporate this component of practicing in my practice and not disrupt my workflow? And so what I've done is I've scheduled just those calls that really don't have to last the 20 minutes, because part of the 20 minutes is actually looking at the data and incorporating the data and sort of digesting it to discuss with the patients. And usually it's a 10 to 15 minute telemedicine visitation with the patient that you then adjust their blood pressure medicines, or you discontinue the program, or you make certain suggestions about lifestyle modification, this, that, and the other, that would be that you would do. And you can pick a day that you could actually do the telemedicine or just incorporate that into your part of your daily schedule. And that's what we've done. We've just incorporated it into our daily schedule, or not so much daily, but weekly schedule, because you have to do it. You bill every 30-day intervals. And so you want to just try to get it on a nice schedule so that you're working efficiently. And I'm available for questions, Gene, as I'm sure you are too.
So, yep. Okay, thanks. So I actually had a question myself.
Okay.
So, because I'm very visual. And so I love the fact that the system you're using actually will ping you, to use your word, right? So if there's any critical value, right? Because from a risk perspective, I hadn't even thought about that I could be days before I would actually realize the patient had an abnormal critical value and maybe had that unexpected result. So, but how do you know exactly? So let's just say you had 15 patients on RPM. How do you know at the end of the day or at the end of the week, or how do you even know that those patients have transmitted the data? How difficult is that? How do you even know who to look at?
Well, I know because I have an app on my phone that pings me every time a patient takes a data point. And I also use a vendor that will call me and let me know that the patient hasn't gotten their data taken in a day or two. And then we can follow up with that patient. So the vendor is very good at being my backstop in regard to making sure that the patients are having their data taken. And the platform that I use allows me to do two things. One is that I can set parameters for being notified if a value is out of range, and then I can use the vendor and I can set my parameters on the vendor's platform to be a little bit higher. For example, let's say I'm monitoring your blood pressure, and let's say I'm going to say, okay, if Gene's blood pressure systolic exceeds 150, the phone's going to ping me, and if it's over 90, it's going to ping me. But let's say I don't want to be called all day and night by the service, but if your blood pressure should exceed 200 systolic and 100 diastolic, they're going to call me and let me know that there was a markedly abnormal blood pressure, and that even though they're not serving like an ambulance or emergency service, it's being pinged to me, and I'm being paged to me or emailed to me, and I'm being notified that there was a markedly abnormal value that needs to be addressed, and either I need to get that patient on the phone, a telemedicine visit, or into the office to address that markedly abnormal value.
Okay, so then so you've got 15 patients on RPM, my hypothetical number, and 2 patients this month had some critical value, high or low, right? That you got pinged. How do you know for sure that you've actually reviewed the data for the other 13? Is there like a dashboard or something that's all encompassing that lists everybody that?
Well, yes, that's part of your workflow in your office, and your champion is that there is that at least the program that I use has a dashboard with each patient there. And then that champion would look through, my medical assistant basically looks through and just make sure that each of those 15 patients is actually looking at the data, and that we're setting up the end of month visit, the visitation, and we're downloading that data, and then we're digesting the data as part of our 20 minutes. And then I get on just like a chat like this about, hey, are you watching your salt intake? Are you taking your medicines? Should we, the usual stuff that goes along with that.
Sure. And how many patients? So what do you think the average percentage, et cetera, of patients who initially were like, okay, this sounds like a great thing to do, but then are not compliant? Is that a big problem, a small problem?
I found it to be a small problem in my in my practice, most of the patients are rather compliant and rather happy that we were watching them and participating with them. In a value-based world now, right? I mean, part of the challenge of a value-based world, as I hear and talk to people, is that how do you, and I just had this discussion the other day. How do you create an environment where the patient reaches out to you first as a primary care doctor, as opposed to automatically going to a walk-in center or going to an emergency department? How do you create that relationship? Because patients have been trained to go to emergency rooms and walk-in centers. Like, think about it. You take your blood pressure. Oh my God, it's 185/92. Automatically go right to the emergency department, and they get an emergency visit. So if they're being monitored by you, right, you've created that relationship. They know you're watching. And if you get pinged and call them and say, hey, your blood pressure is 182/92, why is that? What's going on? And then this happened the other day. Oh, I just had a fight with my husband. That was a knockdown drag out thing. I'm like, okay, well, take your blood pressure again in 2 hours, and we'll see what it is. Or, I don't know, the pressure is very high. So, those are the kinds of things that create that stickiness, if you will, with the provider and the primary care provider, so that the patients are now coming to you primarily as the person, as opposed. And hey, you don't have to go to the emergency room. You can call me, and we've got, that's how we arrange it. And the vendor may contact me directly also if the patient's not being compliant. They'll say, hey, your patient hasn't done a blood pressure in like 3 or 4 days. You need to get on that patient.
That was the other part of my question coming up. So, about that non-compliant patient, how long would it be the end of the month before you find out? Or
no. Well, again, I use a vendor that, I mean, the vendor's successful if you're successful as a provider, right? So the thing about it is that if you let the patient get away so that the vendor can't get 16 data points for the month, that's a bust for the provider. They can't bill, and technically you're theoretically getting charged for that whatever they're charging you, the vendor, right? Essentially, the vendor tries, I think, to charge for the 99454, that transmission of data, that charge, the cost of the transmission of data. And then you get your 99457, but and then so the initiation is per incident of service, so you can only bill that the one time. So really what you're billing monthly is the 99454 and the 57. But again, the vendor, at least the vendor I use, is more of a partner than just dropping off the device. And so what they want to do is they want to make sure that I'm successful. So they're like, hey, you need to make sure the patient is being compliant, otherwise you can't do what you need to do.
Okay, so I see that there's a question in here. It's a little bit off topic, but hi, Dr. Kumar, how are you? So when is EICU going to be covered? I don't think it is covered now. Actually, I think it is covered. I believe that so telehealth, right, for ICU visits is indeed a covered service, Dr. Kumar. Give me a buzz offline if you want. We can talk about that. So that's the one question I see there. Let me see anything else in the chat or anything. No? All right. Okay. Well, good. So I hope that everybody, oh, wait. Never mind. There's a new question here. Have you been finding success being reimbursed by all payers? Great question, Dr. Schwartz. So we know Medicare pays, but what about the 39-year-old that has Cigna or Florida Blue, et cetera?
Well, we've tried them all, and they pay less, but they pay. So, they do. They pay a little less, about, 20-30% less, but they do pay for the services. United and Humana specifically. Aetna also. I don't think I tried Cigna, but I think Aetna, United, and I'm sure United and Humana did pay, and but they did pay a little bit less. And then of course with Medicare also, you know, you have your 80% reimbursement, and then you have to sort of go after the 20% if they don't have a supplemental insurance that covers that.
So, but that question and your answer leads me to another question. So for some of these insurers, like especially like a Humana, the patient may actually have a copay. How have you found that they're charging the patient copay each month, and if so, how has your office managed to collect that for a patient that's not coming in, or have they?
Well, I'm under the impression that we have to try to collect the copay, or the
Yes,
20%. So we in fact try to go get the copay and the 20%. We don't send anybody to collections though, Jean, but we do try to at least send a bill and try to collect that money.
Awesome. Good answer, Dr. Schwartz. All right. Let me see. Is that another question or the note? Let me just mark that. I think that's it for the questions. Final call for everybody in case you have a question. If not, all right. So Cynthia, did you want to say any final words? Did Dr. Behrens, was he able to get here? Let me see if I can see him.
Muting. Thank you very much, Jean and Dr. Schwartz. It's interesting because the BCMA has been approached by many different vendors and was looking, and I don't know if Dr. Behrens was able, he or his staff, to get on, but he has talked with several and hasn't come to a conclusion yet, really.
Yeah, I see that Dr. Behrens is on, so I've given him the ability to talk if you'd like to. Hi, Dr. Behrens. Did I catch you unaware? I'm good at that. But he may not even be aware I put him on. So, yeah.
He usually does talk. I can say that. I'll text him because he's very interested in this subject.
So while we're waiting to see if he can log, I see that there is another question. Can you please clarify the difference in chronic care management and principal care management for billing and services differences? Okay, so that's a great question. I'm going to give you the Cliff Notes version because chronic care management and principal care management deserve their own session. But if you think about it, chronic care management was really intended for the primary care physician, the internist, family practice, gerontologist, et cetera. For that non-face-to-face management of a patient who has 2 or more chronic diseases, right? The doctor, the nurse practitioner, PA is supposed to develop a plan of care for those conditions and what the patient's goals are. And then your clinical staff and that patient would be interacting in the course of a month, time-based codes for the monthly care management again, that you have to meet a 20-minute threshold to be able to bill. Very successful, by the way, in line with some things that Dr. Schwartz was saying at the beginning of his presentation. CMS actually has had engaged Mathematica Policy Research, one of the very large national statistical analysis firms, to do a study. And they found that in patients who had been Medicare beneficiaries who had routinely been receiving chronic care management over an 18-month period, and a small cohort of all the Medicare beneficiaries, did physician payments go up? Sure, doctors are billing for chronic care management that they hadn't before, right? But overall Medicare costs and expenses went down something like $74 million, actually, $74 million for, and this was only the first couple of years of chronic care management. So after that got up and running, and CMS is going, okay, so this really seems to be having its desired effect, right? Patients aren't going to the emergency room as often, aren't appearing in the hospital. They're happier, we're happier. Everything's working good, but they started hearing from specialists that said, hey, wait a minute. One, if the primary care physician is taking care of these 2 chronic conditions, I can't also bill for any care management. And very often, as I'm the cardiologist, the pulmonologist, the patient may have one of the conditions that I treat them for that is out of control, right? Could really utilize some shepherding in the guise of care management, just like chronic care management. So CMS in 2020 created principal care management, which is targeted for the specialists. So here's the difference. It's really only one, other than the codes are obviously different. As opposed to two chronic conditions, the specialist can bill for principal care management when there is one chronic condition that they are addressing. And it's expected, as opposed to chronic care management, the definition says that will last at least a year until the death of the patient. For principal care management, the exacerbation, progression, whatever it is of that one chronic condition that might incite a physician to do principal care management might be something out of control for just 3 months. It's actually not expected to last longer than about 3 to 6 months. Whoops, sorry about that. Hopefully she'll be quiet in a second. Cynthia knows. My whopping 10-pound, barely 10-pound cockapoo is trying to protect me with her life. So that's the main difference. The nicest things about principal care management, I remember when it came out last year, I scoured the fee schedule to see. I wanted to know, one, okay, if the specialist is providing principal care management, can the primary still provide chronic care management? The answer was clear yes. So nobody has to worry about stepping on the primary's toes. Second question I had is, okay, but what if the patient's AFib is really acting up and the doctor wants to really have his clinical staff interact with the patient for a few months to get that under control? And the pulmonary doctor wants to do the same thing for the COPD that also happens to be out of control. Can we have two specialists also billing principal care management in the same period? Yes, right? So there aren't any restrictions as to who or how many physicians can, as there is for chronic care management, only one doctor for chronic care management in a calendar month. But of course, caveat is the service needs to be medically necessary.
Gina,
Now,
I have a question.
sure.
If you have given your patient a remote patient monitoring kit, and I think I've asked you this before, if you have a remote patient monitoring kit out and about with the patient and you were billing 99454, the transmission of data, in lieu of billing a 99457, let's say the acute period where the patient's situation for remote patient monitoring has ended, but you want to still transmit the data to use for your chronic care management, monitoring the weight, this, that, and the other. Can you incorporate that transmitted data of 99454 into your chronic care management plan and bill for the 99454? Is that allowed?
Yeah, there's no conflict, right? There's no conflict of the two services, right? So yeah, and I see Dr. Behrens has his hand up. Okay, Dr. Behrens, you should be able to talk if you want.
It's his microphone.
Okay, so.
I think he was trying to talk.
Yeah, I saw his hand up. So Dr. Behrens, if your mic isn't working, you could type something in the chat or the Q&A box.
Okay. Okay, he's not really sure who he can trust. in simple terms. Yeah, he's not sure who he can trust. He's interviewed many and he's not really sure who he can trust.
So I appreciate the doctor's caution, because there are indeed too many vendors out there who will tell doctors that, oh my God, if you do this, you can make $50,000 a month, right? And that may sound outrageous, but actually, Chris Acevedo, my son, and I actually uncovered someone recently who was told, a doctor, that they could make $50,000 a week by doing some service that oh no, it wasn't my son. It was one of the healthcare attorneys I work with. And because it was so egregious, I actually told the attorney, I said, you need to report that to the federal government. Someone needs to go after that company, right? Because it clearly was the bad guys. But I would, for any of these things, whether it's chronic care management, remote physiologic management, any outsourced service, good to be cautious, but ask for references for physicians, right? And if there's an agreement, which there typically would be, actually read it, docs, right? Read it. Read what it says you're obligated and what the provider is obligated to do, right? So that you go in with eyes wide open, to use a phrase, right? So is there a period of time that a doctor has to sign up for the vendor that you use, Dr. Schwartz?
No, I mean the providers can use the service as they see fit, and there's no contractual obligation where they're bound to it. The service that I use actually will send the consent with the kit for the patient, and will actually make sure that the patient's appropriately consented. They will sign a BAA with the provider, so they're trying to be as up and up as they can. No, the service has never told me I can make $50,000 a week. As a matter of fact, they probably told me that. Just remember, the tallest blade of glass, the tallest blade of grass is the first one to get cut. So you probably want to be.
Oh, there you go. Oh, I like that.
Yeah, you probably want to be somewhere right in the middle of the bell curve and not utilizing this service. Remembering, it's not about making money; it's about patient care that we're really doing this. It's just that you're allowed to get compensated for providing this care for the patient. So that's what I was told.
Yep. No, that was a good message, right? And again, oh, Dr. Barron, background noise.
Do you hear me now?
Oh, there you go.
Oh my God.
There.
Oh, finally. Okay. I'm just having an issue with my computer today. I'm terribly sorry. First of all, I want to thank you very much for putting together this webinar. It is very timely. Ever since the beginning of this year, I know that the BCMA has been deluged with a number of different vendors, and I've looked at them all, and you'd be amazed at to what extent they're willing to not disclose fully as to what they're doing and not doing, and it just to me it really would border on anti-kickback and Stark Amendment rules and outright fraud. It's very disheartening to see that these people just think of us as a bunch of stupid idiots and not realize the consequences if you don't proceed in the right path, as you have guided us during this webinar. So I think it's incredibly important just to understand the nuts and bolts of this. Getting to a vendor that will basically amalgamate the information, put it onto a dashboard. It would be lovely if we could have one that would be free to everybody, and then upload separate HIPAA compliant portals to physician specific, and then that way you don't have to rely on somebody else. We'll leave that up to somebody that's a little bit more entrepreneurial in creating something of that sort, because that seems to be where they make their money, aside from trying to lease you equipment or make you buy into the equipment and then spread the cost of the equipment over the first several months of billing. And I mean, I've seen every permutation of hocus pocus, and it's to me it's very, very concerning. So I just want to caution everybody before you get involved with this. That you're going to be encountering a lot of vendors out there that are going to be presenting many ways to bill and really think that you're not savvy to what needs to be done to make this a worthwhile endeavor. So that's all I can say at this point in time. I'm sure you're going to have another version of this seminar in the future, because as you know, the CPT codes can change even from the point in time you give us a webinar to several months later, and then you're just sitting there wondering what the hell is going on, and you're billing, and then nothing is coming back, or they're saying it's invalid codes. And unless you're getting real-time information back as to make sure that your coding is current, You just need to understand that. So
Yeah, and Dr.
aside from
Behrens, I
that,
think,
this has
I
been very,
think-
very helpful, and I'm very glad that you were able to put this on. Very much appreciated.
thank you. And to your point about the code changes, I think Cynthia may have already booked me for January
Now I don't hear you.
to
Oh.
do my annual coding and compliance update for
Mm.
the medical society. So,
Right, right, right,
yeah.
right. Absolutely.
All right. All right. So thank you all very, very much.
Thank you.
I can't hear anything.
Cynthia, you can hear me, right?
Yes, I can.
Okay.
Thank
Poor
you.
Dr. Behrens.
Yes, I can hear you. I know, I know. But
Yeah.
thank you very much, Jean. I look forward to seeing you soon.
Thank
and
you.
Zoe.
Thank Dr. Schwartz.
Thank you, Jean.
Thank you, Dr. Schwartz.
Thank you, Cynthia.
All
Thank you
right.
for having me. Thank you,
Nice
Dr.
to
Behrens.
meet
Bye, everybody.
Likewise.
Bye. Have a wonderful day. Happy Labor Day weekend.
Yes. Enjoy
Yes.
the 3 days. Hopefully
Yes.
everybody will stop the labor.
Yes, right.
Yeah.
You have fun in New York.
Have fun in New York.
Oh, I will. All right,
Yeah.
guys.
Oh,
Bye
nice.
now.
Bye-bye.